Welcome, everyone. I want to welcome our global radiology community from different parts of the world to this webinar. We have radiologists from 80 countries who stand united more than any other times to fight this pandemic together. I know many of you would be listening to this webinar in the recorded version. No matter how you're listening to this, I would like to extend a warm welcome. I would like to start with positive thoughts. One is of my grandfather's teaching of seva, or selfless service, which inspired creation of health for the world. It is time to choose compassion and kindness to help our fellow human beings together during this time. Secondly, I want to quote Nelson Mandela with this beautiful quotation. Part of being optimistic is keeping one's head pointed towards the sun and one's feet moving forward. We all will welcome a bright future together like a global family after this is over. I want to welcome our co-moderator, Dr. Bill Dillon. Dr. Bill Dillon is the co-founder of Health for the World and Executive Vice Chair of Radiology at UCSF. Dr. Dillon has helped shape many of the Health for the World initiatives. Thank you, Bill, for joining us. Next, I want to welcome our excellent panelists today. The format is simple. Our six panelists will present the Department and Radiology Society's experience with COVID-19 for the first 40 to 45 minutes. Then we have questions in the video format, which have been submitted by you from around the world. You can also submit the questions in the Q&A box in the Zoom. If we have time, we'll be able to address the questions. And if we don't worry, we are making notes and we will answer the questions after the session via email. I would like to welcome our first panelist. Our first panelist today is Dr. Sherry Cannon. Dr. Cannon is a professor and Whitton Stanley Endowed Chair of Radiology at University of Alabama at Birmingham. And Dr. Cannon will be talking about COVID initiatives at University of Alabama.
So thank you. I really appreciate this opportunity to reach so many people, and I hope you will forgive me and allow me not to use PowerPoint. Sometimes Zoom is a little challenging to engage with people, even more so when your faces are so little and tiny. So I'm going to do this without PowerPoint, so hopefully that'll be okay. Let me paint the landscape of our practice here at UAB and in Birmingham, and then kind of tell you how we're emerging into what we're kind of calling the new normal. We have one of the largest public hospitals in the nation. We have about 1,200 beds, and typically we run about 98% occupancy. Unlike some of our other academic institutions, we really don't have any nearby academic facility. The closest facilities are in other states, so we really cover the entire state. You know, with the COVID crisis, and for us, we officially declared it on, interestingly, Friday the 13th. We had to do a fairly quick pivot. We had to address our occupancy. We needed to have room to bring patients in-house, so that was a challenge. Of course, we canceled all of our surgeries that were not urgent or emergent. And in the span of about 48 hours, we canceled 50,000 ambulatory appointments and transitioned to telemedicine. So it was a fairly quick pivot, and I'm sure that that's true for all the other panelists as well. Let me kind of tell you the three roles that I have, and so you'll understand my perspective as we talk about the road going forward. So one, I'm the chair of radiology, so oversee the radiology operations. But probably more interesting in this crisis even than that is my role in ambulatory access. I've served as the medical director for ambulatory access for UAB Medicine for several years, and in this role, oversee access to our 1,200 physician practice. We see about 5,500 patients a day, including imaging in that, but also routine clinic, evaluation and management appointments and procedures. So it's interesting in this role, one as a radiologist, but two with a quick pivot to telehealth, which is something I know nothing about, and now I'm fairly well versed in it. So that's been an interesting transition. Probably the third role I've had in this is probably the one that's been most impactful, the least defined, which is days before the COVID crisis. We brought my parents to town because my father was being diagnosed for what turned out to be base of tongue cancer. So I got to see the perspective from a patient entering into this COVID crisis, and at the same time, my son was to be hospitalized for epilepsy inpatient monitoring during this crisis. So I interesting roles. And I bring that up because I personally think it's this latter role that has probably been the most impactful for me. So this quick pivot, reduction of the surgical cases, well, that leads to a huge surgical backlog. We have over 2,000 surgeries that we need to plan. And the state right now is actually still increasing number of COVID cases. So we have not peaked yet, but it looks like by all models that we're going to have more of a plateau, that we will have succeeded in leveling that peak. So that's the good news. And also UAB has maintained a similar number of inpatients over several weeks, roughly 50 to 60. So we're not going to have the overwhelmed status that many people unfortunately had to experience. So we're actually coming back online to more routine cases starting today. We started a little bit last week, but really starting today. Now, I don't think we're ever going to go back to complete normal, and that's why we refer to it as the new normal. The telehealth platform will remain. And I think as imagers, we have to learn to integrate with that. And I'll share with you some of the challenges that we had. One, bringing these surgeries back online. Our surgeons are incredibly anxious to get back to the OR, but clearly some of these patients need preoperative imaging. And how do we prioritize that as we're bringing patients back to the clinic? And that has been a big challenge. And what we have done is actually provide list Excel documents to each of the clinics with all of the COVID cancel imaging patients and ask them to help us prioritize these patients. And that's been very positive because it has engendered engagement by our clinical colleagues, and they're working with us so they understand the challenge that we have. I will tell you one of the unforeseen circumstances during this time was as we had our surgeries on hold, as ambulatory visits were transitioned to telehealth, patients were still interested in having their imaging, even though everything else was on hold and none of it was emergent. So we actually, unfortunately, lost some of our patients to imaging at outside facilities. Not many, we think it's few, but we don't really have a way to fully capture that. So that's been one of the challenges. As we move back to ambulatory imaging, as we prioritize those patients, and particularly probably MR is the most challenging because utilization is so high. Procedures are a challenge too, and how we prioritize the procedures. As an example, it's hard for us to know. Many of our FNAs were put on hold, which is fine, but some of those may be patients who actually have more aggressive thyroid cancer, so we need to move those up in prioritization. The next thing that was considered by the clinic is how are we going to socially distance 5,500 visits a day? And initially there was conversation around having the cars serve as the waiting room. This made me cringe a little bit. I couldn't imagine that number of patients being managed from their cars with text to tell them when to enter the facility. I can imagine some of our patients would need 30, 45-minute lead times to get to where they needed to be. Fortunately, we abandoned that concept. We are now bringing the patients in-house, but we're scheduling significantly fewer. We have an incredible number of signs throughout the clinic directing them where to go, where not to go. We even have floor signs in the elevators as to where to stand because the elevators are going to be a huge challenge. We've redecorated the whole clinic, all 5 floors, moved furniture around so that it forces social distancing. Of course, we take temperature at entryways, and we've actually implemented new thermal scanning, which is interesting. When I first investigated the thermal scanning, it reminded me a lot, and this will age many of us, the Predator movies. And it's really important how we communicate to our patients. What are you doing, you know? And can you imagine pulling someone out of a line of people coming into the clinic and explaining, you know, you have a temperature, you can't come in. We're pulling our patients back in-house, but as a department, we're still going to maintain social distancing, which is a challenge with our reading rooms because like most places, space is a valuable commodity. So we're having to be very creative of where we distribute workstations. Now, I would like to say we were incredibly genius with distributing workstations to home. But actually, I must say, a little bit of dumb luck right before crisis. We had invested in over 20 new PACS workstations to replace PACS existing in the hospital and the clinic. These were all in boxes ready to go. So when we transitioned to the COVID crisis, we were able to deploy 25 workstations in homes fairly quickly over the course of a few days. And so that's been really, really key. But one of the things I want to emphasize here is the importance of going forward and how we make decisions. Clearly, this has been a huge financial hit for everyone, and millions of dollars have been lost by all of our health systems. And so we have to figure out a new normal that's financially viable. But many of these decisions we're making now are not the most cost effective. We're reducing throughput, we're reducing efficiency, we're reducing our schedules. So clearly costs are going to go up and revenue will be low. But as leaders, I think that's important. We have to make those difficult decisions. And finally, I want to talk a little bit about communication. We cannot over-communicate in this environment to our staff, to our faculty, and most importantly, to our patients. And we have to do so very clearly because there's a lot of confusing information, and we need to educate our patients in a way they understand. We need to understand how this impacts them. And we need to remember that our decisions while keeping them safe, such as visitor policies, can be incredibly isolating. You know, it broke my heart to see my father come up here every day for radiation therapy alone. He couldn't be accompanied by me or my mom. And we need to realize that as we move forward, how we can pull our patients in, keep them safe, but also understand the psychological impact that they have and know that their fears are probably even greater than ours. So thank you for this opportunity, and I look forward to the question and answers.
Thank you so much, Dr. Cannon. This was excellent. Thank you for sharing such important lessons and also the personal story of your father. I can understand because my sister, delivered a baby this week, and I couldn't go to see the baby, and the visitation policies are just, in the COVID era. So thank you so much. I really appreciate this. We'll move to our next panelist right now. Our next panelist is Dr. Dushyant Sahani. And Dr. Dushyant Sahani is professor and chair of radiology at the University of Washington in Seattle. Dr. Sahani is a leader in abdominal imaging and will be talking about radiology preparedness in the COVID-19 pandemic, experience from University of Washington.
Dr. Rehani and Dr. Dillon, thank you so much for this kind opportunity to connect with the world as we all collectively deal with this unprecedented COVID-19 pandemic. Now, Washington State was the ground zero in the United States as it was the first hit by COVID-19 pandemic. And, we have seen tremendous progress, and this curve basically illustrates that, after the peak in first week of April, there has been decline in number of patients, new patients, as well as death. And we are almost towards a flattening of the curve. And that is highly reassuring news. Now, this has been possible by combining science, research, the commitment to patient care, as well as common sense measure that we all are familiar with. Now, we all know that the COVID-19 pandemic has endured tremendous hardship to our communities, population, and healthcare organizations have also been hit pretty hard. And this is due to many factors. One is, as Dr. Cannon illustrated, the lost clinical revenue as we could not take care of our scheduled patients, the new revenue related to COVID-19 because of PPEs and other measures which were very expensive, and also lost opportunities for starting new services that one had planned for. Now, for the University of Washington health system, the projected losses would be more than $500 million by the end of this pandemic. Now, your thought is always to try and recover faster, given the pressure we have from finances, and look for mitigating strategies. And as we learn from this pandemic, the science supports that. First of all, we are currently in Washington, we are just above the hump of the acuity of pandemic, but the pandemic will stay with us for a longer time. So this is a classic, the hammer and the dance curve theory, where the initial measures that have been put in place are the hammer measures to prevent overwhelming the health systems with a lot of cases coming. But there is a protracted course of patients who might be positive till we have a vaccine or a good therapy. And therefore, one needs to be cognizant of a longer term strategy. Now, as we think about recovery, I think we have to remind ourselves of some basic principles. First of all, the operation ramp up has to be thoughtful and slow. One needs to take multiple phases. We need to regain the trust of the patient through various measures showing that we are there to protect them, but also care for them when needed. We need to also protect our workforce through all the measures that I will describe subsequently. Now, the University of Washington health system is complex. It has many affiliate hospitals, and it becomes challenging as you manage the patient operation. So first thing, the communication is key, standardization is key. We created a steering committee. Now, the goal of this steering committee is to accommodate the surge in imaging as we move into more normal operation, and whatever redesign we make in our scheduling process can be applied across the sites, and that makes the process slightly better and more engaged. Now, what we did is we are proactively scheduling deferred imaging exam by communicating with the patients through automated text messaging, and we are keeping it very simple for patients to change their appointments by simply replying to. We are leaving many options for them to reach out to the referring physicians or as well as to the imaging centers. We are mandating all the patients wear PPEs, and we provide them at the time of appointment. It's critical that we identify and protect vulnerable patient population, and we know who they are. And preferably what we are doing is we are scheduling them early or late in the day, and mainly outside the hospital settings where they will be less at risk. We are expanding testing to all the IR procedures, especially the aerosol generating IR procedure, except the minor procedure. And this is in policy, which helps protect patients as well as providers. We are taking all the measure to ensure there is continued physical distancing. This includes redesigning our waiting areas, putting a lot of signages here, as you can see. You can see this is an example of a cancer center where we have created these partitions so that there is a social distancing maintained. We have restricted the entry, so patient and maybe one family member is allowed to accompany the patient and be in the waiting room. We are creating staggered appointments to reduce overcrowding in the waiting rooms. We are also removing anything some patients might touch, like non-essential items like magazine, brochures, coffee machines, and all that. Moreover, we clean all these waiting areas after each patient use, and someone puts a sticker that it has been cleaned, so other patients, when they are seeing it, gain the confidence. We have applied mandatory masking policy. As we know, hand hygiene might not be visible all the time, but mask is very visible and powerful. It sends a message that we are protecting our patients and the providers, and I think it builds the confidence, so that's the policy. We are also looking at some of the technologies, including allowing patients to wait in the car, especially when we have a surge and an increased volume in patient, and as Dr. Cannon mentioned. Now, it's critical that as you gain your volumes, that we are cognizant of improving, having more workflow efficiencies, and this includes using technology for smart scheduling, shorter exam time, looking at some tools for auto protocoling. And we also have to continuously monitor and communicate these measures with our workforce. Now, I think that depending on the size of the system, if you are a big health systems like ours, you have to think about some entrepreneurial activities that I have listed, and we are exploring options like getting contracts for teleradiology, some contract research organization work. We are also exploring some new business models, including new services on the population health and wellness side. So in summary, I think my final thoughts are to those who have tuned in and who will be watching this later, that healthcare is one of the best human endeavor. And this pandemic has validated the importance of healthcare. And it's also critical to remember that our patients need us more than ever. And so we need to stay nimble in our approach. We need to be cognizant of the work pressures, but more importantly, don't give up on our patients, stay optimistic. Good days are ahead of us. Thank you.
Thank you so much, Dr. Sahani. Love the note of optimism and especially your experience since you were the ground zero is very good. And the entrepreneurship ideas for preparing for the, reopening are excellent. Thank you so much. Really appreciate this. Next, we have Dr. Alex Norbash. Dr. Norbash is the chair and professor of radiology at UCSD. Dr. Norbash will be talking about COVID-19, the road forward for the radiology panel.
Dr. Rahani, I'd like to thank you for the invitation. I'd like to congratulate you and Dr. Dillon for the work you've been doing with Health for the World. Many of you have seen this Chinese character, Weiji, which Al Gore famously utilized during his Nobel Prize-winning speech to talk about how danger and opportunity typically are seen hand in hand. And so it's easy to segment what's happened here observationally at day 98 into 3 different focal elements. The first is clearly dealing with the crisis, making sure that we're doing what is necessary to address the crisis. The second topic, which is the interesting space, is what are the opportunities that are created and how can those opportunities be leveraged so that we use this as a transformational chance. And the third and the natural segue from leveraging opportunities created is understanding how we learn from this instance and how we apply these opportunities and solutions and realizations to future crises. And so when you're looking for opportunities in a time of crisis, you can go online and there are numerous tomes and advisory spaces that tell you how to tackle this. And one of the well-written ones is done by Wharton. And we will get to some of the elements of that. Again, dealing with the crisis, leveraging the opportunities, learning and applying for future crises. But I'd like to talk about my observation of what I saw happening. So the first thing I saw happening at the ground floor was the CEO establishing weekly town halls and semi-weekly chief huddles, in addition to our mimicking the same. And in the radiology department, having weekly town halls specifically about the COVID crisis, noon on Mondays, having anyone who wanted to call in, ask questions, and we could discuss solutions and have a closed loop connection. So as Dr. Cannon said, communication forms the core of a reaction in this instance and gives you a landscape from which we can learn and find the opportunities and move on them effectively. What we also noticed, obviously, is the operational challenges that Dr. Cannon and Dr. Sahani have already mentioned. How do we create open capacity? And then how do we deal with the COVID patient specifically? Whether it's PPE, whether it's scheduling, wipe down, and how do we learn best practices? The third thing that we've all realized is the financial aspect. Given the amount of a drop that we've all had, this is a financial crisis for all of us. We need to understand how we're going to make payroll and keep the faculty and staff. And again, that connects back with the communication need, the mandate. We also realized that we had technological challenges. We did not have a highly developed telecommuting operation. And so in rapid order, we had to purchase a number of workstations, install them in faculty homes, and figure out how we're going to do this in successive waves, realizing that we're 3 months only into an 18-month process until we're all vaccinated. And so we need to have a robust telecommuting understanding. And finally, the cultural aspects of what's happening. Because as the faculty choose to telecommute or sequester in smaller and smaller workspaces, remote from the residents, now all of a sudden we have to make sure that it doesn't appear as though we're creating a human shield using technologists and residents and hiding from danger ourselves. Let's talk about leveraging the opportunities created. Our organization is seeking to be more data-driven by the day. And what COVID has done for us is it has positioned us effectively to be a data-driven organization, because now there are scorecards that are pushed to us on a continuous basis. And it has become the reference point for many of our conversations. So for the first time, other than what we all have done in terms of focusing on RVUs and financial productivity, for the first time, we're talking about our operations by using data-driven scorecards. So this may position us to become a more robust data-driven organization, which is a good thing. What we also have had to do is identify our unique and appropriate strengths. For example, we have an artificial intelligence laboratory that does predictive analytics. We also have a huge population science arm for imaging and adolescent brain cognitive development. And so those two areas have submitted multiple grants in the past couple of months that have been funded as a direct result of our recognizing that these are strength areas that overlap with the needs for COVID and mobilizing those groups effectively. And then finally, what we're trying to understand in terms of our uniqueness, we also recognize that as the UC system, we have great strengths. We cover 16 million covered lives in the state of California. We have much that we can share and much that we can learn. And individuals like Atul Butte, who's our chief data officer for the entire University of California system, has created data warehouses and scorecards that are now pushed to us as radiology chairs. So we have an understanding of what's happening for our patients in the UC system. So a snapshot example from our scorecard includes such things as licensed ICU beds, total ventilated patients, in-house COVID patients, and total discharge COVID patients. Our governor moved very quickly in terms of the shelter at home mandate. And the result of that has been a very low flat line without a clear peak. And so all of our different UC systems have realized that we have not seen the volumes we initially anticipated. The good news is that we have well patients, and we also have high survival rates, even on our intubated patients. We have a 75 to 78% survival on patients who are intubated, which is the corollary of what we're seeing in other states. The bad news is we don't have herd immunity. We're somewhere below 1% currently in terms of antibody testing. This is a snapshot of 1,650 employees we've tested to date. Only one was PCR positive, and that was a person who was in orientation. And we've only had 14 employees on the front line who've been antibody positive. And so this is an example of the analytics that we're now utilizing and that is becoming part of our conversations on a daily basis. 3,325 people tested again. You can see the percentage who are positive, and that number is obviously dropping as more testing is being done. And this is an example of a UC snapshot. The graph on the right in the upper corner shows you the aggregated number of positive patients. And so we have less than 1,600 confirmed cases out of 16 million covered lives. So as you can see, the incidence is very, very low, and each of the lines that you see reflects each of the 5 UC medical campuses. We're the orange line at UC San Diego. This is an example of an opportunity taken. Albert Shao runs our AIDA lab, which is an artificial intelligence lab, and he has an incredibly promising resident who's a first-year resident, Brian Hurt. Brian and Albert have assembled an artificial intelligence package that highlights abnormalities in the lungs. It helps you see pneumonia before you actually see it with your own eyes. So this was done based on training 40,000 images in very rapid fashion. It has support from Amazon Web Services. And again, it's an example of an opportunity taken with the COVID crisis. And again, this is core to what we do on a daily basis, understanding how we learn and how we are experimentalists. So again, what has this opportunity shown us? Well, it's shown us that we have to commit to adaptive experimentation, whether it's with PPE, whether it's reconfiguring rooms, whether it's communicating together. We have a SCARD, the Society of Chairs blog, and there has been continuous exchange of information as there is with LCIR. So looking at how we learn as progressively larger groups and share information, that's part of what we have to do to be adaptive experimentalists. We also need to understand whether our architecture and our culture guarantees agility. And where that is not the case, we have to make the changes. whether the architecture is the management architecture, whether it's the strategy architecture or the financial architecture. There's much work to be done based on what we've seen in this instance. And then finally, I'd like to talk about leadership. First of all, as a differentiator in terms of helping an organization succeed or fail, this is where leaders have a chance to really make a significant difference. It is in times of crisis when leaders are looked to for direction, for reassurance, for communication. It's not easy, it is unrelenting, but it's exactly why we're here. And then the final point I'd like to make is this is an exceptional test bed for identifying and cultivating talents. It's natural to understand that in times of fear and in times of concern, when you're worried that your family could become ill if you're exposed, that people would become selfish. But what's actually happening is we're seeing remarkable instances of leadership. And so I suggest that we all focus on the opportunities and understand how we can transform to be in a better place. Thank you, Dr. Hani.
Thank you so much, Alex. This was excellent. And I love your message on leadership. We have leaders of radiologies from different parts of the world who have joined us here. And we are really inspired by all the panelists today and the inspiring messages. Thank you so much. Next, I would like to move to Dr. Neil Helen. Dr. Helen is the radiologist in chief and chief of cardiovascular interventional radiology at Tufts Medical Center in Boston. Dr. Helen will be talking about radiology in the COVID world moving forward. Thank you so much, Dr. Helen. Give me 1 second. I think you might be mute. We can just unmute you.
Unmute myself.
Perfect. We can hear you.
I can do this myself. Welcome, everyone. And thank you for inviting me to share a little bit of insight in what we've done. I am at Tufts Medical Center, and Tufts Medical Center is the primary teaching hospital at the Tufts University School of Medicine. And we're in a kind of weird position because we're in Boston, and if you throw a squirrel in Boston, you hit a university hospital. And so we're the smallest of the big teaching hospitals. That we're still a level 1 trauma center designated for both adults and pediatrics, and a designated stroke center. And that's an interesting part of the dilemma that we faced, because while almost all of the hospital has been consumed with COVID operations, expansion of COVID ICUs, kind of usurping of med-surg beds. We've even taken over the pediatric intensive care unit as a COVID unit. We still have to deal with level 1 trauma, and we still have to deal with strokes. Now, interestingly, what we've seen is that with the number of cars on the road decreased dramatically, the actual number of vehicular traumas is down, but the severity is up. Strokes are a problem because we're wondering where they all are. Strokes and heart attacks and normal operation, things like that, we've seen a dramatic decrease in it. And one of the problems with the COVID crisis is we're concerned, where is this reservoir of people? Are they hesitating to come into the hospital? So that's one of the things that, as we start to resurrect normal operations, we're hoping that people are going to come back in for those things if they're concerned. We're part of a network. We're not a very big network, but we're part of a network. And one of the things that that meant was that one of our hospitals, Lowell General, was actually in a Massachusetts isolated hotspot. They filled up very quickly, and they became a conduit, basically sending their highest complexity patients downtown. Melrose Wakefield's a small community hospital. They've been kind of holding their own. We had one mostly closed hospital that we were outfitting as sort of a reserve area to basically house patients who couldn't go home but needed some small level of care that would not be accepted by nursing homes. We have not had to operationalize that yet. There are still challenges in getting patients out of the hospital and placement. So we were tapped to figure out how to rapidly adapt to this new world. And I would say that Tufts was very proactive. Our management at the top, at the hospital and at our physicians organization, were really proactive. And we were one of the earliest hospitals to really dig into this deeply with a ramp down of our clinical operations. We were seen as a smaller hospital as more vulnerable to being overwhelmed. So there was a very early effort to ramp down patient encounters in clinics, ramp down the operating room, interventional radiology, anything we could to decrease not only the number of patients coming through the hospital, but the risk that those patients might need to be actually admitted to the hospital, and even worse, to the ICU. So the OR was closed down to all non-emergent cases, or emergent cases and cancer cases were still being operated on. We ran a normal routine of, I believe, 2 ORs ready and operating with scheduled cases, and then an ability to ramp up if needed. We actively rescheduled all non-emergent imaging. So a resident or residents in each section, in conjunction with an attending, actually reviewed every ordered study, and we decided very early on in March to push back to May 11th. Now we've had to push back to May 18th because the governor has continued our stay at home until then. But we, back in March, called every attending, ordering physician, every patient, and we rescheduled what could be rescheduled into the future, and urgent cases were scheduled to be done. So we maintained oncology operations and some other critical operations. Stockpiling of supplies early on in this crisis, as far back as December, the hospital started putting out orders and stockpiling supplies. Turned out that one of the hardest things to find was IV tubing, because one of the lessons learned was that we had to move the IV pumps into the hallways and out of the patient rooms so the nurses could maintain them. There became a shortage of IV tubing, and that was one of the things that nobody had ever anticipated before, because who knew you needed 20 feet of IV tubing for every patient, for every line. Physical plant enhancements, make sure that we had enough negative pressure rooms, just physical walls and doors in places that we never thought, rooms that didn't have ante-rooms to get dressed and undressed in. Whoever knew donning and doffing were the new keywords of life. And then how did we manage a walk-in center for testing? We very early on instituted this testing center. What did we have to do with challenges in the department? We did not have read-at-home capacity in place. We routinely do not supply, the hospital nor the physicians group supply workstations for home. Some of our staff had personal workstations. We've always allowed people to read from home on call if they have appropriate hardware. And most of that was for cross-sectional. So our body imaging and our neuro people were pretty well set up. We had a whole bunch of review-only stations, but a very few full dictation stations. So we had to figure out, how do we get out at a minimum speech mics to everybody. We had a very early encounter with staff exposure and quarantine. And one of our great fears early on was, of course, that a number of our physicians and residents and technical staff and administrative staff would get COVID, be quarantined, and not be able to work, or worse. We had a very early encounter. 2 of our residents were out, tested positive, then decided to go out partying, and that exposed some of our IR technologists. So we ended up with a bunch of people on quarantine, and that caused a lot of strife and stress, because the issue came up is, what do you do with quarantined and actually test positive staff? You have to have some plan about pay and benefits. Do they have to use paid time off? Do they go on mandatory furlough? Are you paying them fully for their time off? These are all issues that probably should be thought of in advance, because they will cause strife when they arise if you haven't thought about them. We also needed to plan for operations with limited staff, and we started storing some of our radiology staff at home because our volumes were down anywhere from 8, I would say, 48 to 80%, depending on which section you're talking about. In an area like mammography, where we were only doing diagnostics and biopsies, the impact was much higher. In interventional radiology, where we became the central line and arterial line service for the hospital, although what we would consider the good cases all were rescheduled, we were still maintaining volume, doing lines and other emergency cases. We also platooned our residents, rotating half the residents into the hospital and half out. And we established a minimum number of radiologists on site that we need to maintain operations. And it turns out we needed one physical person in neuroradiology, one in body, all of body imaging, and to cover contrast reactions and do emergency fluoros. We had one person in mammo doing diagnostics, one in pediatric, and two in IR. And everybody else was working from home. And so we provided a minimum spec to people. We gave them recommended places to buy things. We were just at the beginning of a workstation refresh and had no extra hardware. The hospital was exceedingly hesitant to allow any hardware that was in the hospital to leave and then have to come back. And so they basically said, if it goes home, it's probably staying there. And because I did not have reserve workstations to substitute, we had to make the hard decision that workstations weren't leaving the department. To that end, though, we did designate a number of workstations as what we call remote desktops. So if people couldn't provide appropriate hardware, or if they were Mac users, we were actually designating these workstations as remote operation stations that they could manipulate from home remotely, actually be running all the software at the hospital, but so they could use their Macs, they could be viewing their images at home. And as I said, we did order a bunch of speech microphones and distribute them. We had to figure out communications, and the hospital did a really good job with communications, both with the department and the hospital. I maintain at least one Zoom check-in a week with the whole department. We've had interactions with techs and administrative staff, and the hospital has run one or two whole hospital town halls per week, and the physicians organization has been running one check-in per week as well. We've had to figure out how to do remote resident readout. When you've distributed your residents and your staff, the development of a Zoom process to do your actual readout with your residents was something that was somewhat foreign. We figured it out, and it actually works pretty well, but I have to say, most of our staff miss the interaction, the one-on-one personal interaction with the residents. And it's the same thing we're having to do with technologists discussing protocols in patients, all done remotely. Remote protocoling, yes, this is all done electronically, but oftentimes there's a lot of iterative interaction between the resident or the physician attending protocoling it, and the person that's ordering it. And so this is now being done at a much a different pace. It's remote. We've instituted telehealth for our interventional radiology clinic. Each one of our interventional radiologists got an iPhone, and we've been coordinating televisits so we can keep in touch with our patients. Something that also arose was what to do to accommodate staff with special needs. What qualifies as a special need? Do they actually have to have a physician attestation to keep them out of the hospital? Are there Americans with Disabilities Act implications that need to be dealt with? And in some instances, should they take a voluntary or involuntary furlough? We only had one physician who claimed asked for accommodation, and the section that person works in basically worked it out so that they can continue to work from home and not have to come in and do in-house shifts. For operations, how do you keep your portables techs safe and your equipment clean? They're our front line. If you talk about who's the front line in radiology, it's the ultrasound techs and the portable x-ray techs. They're the people that are going up to the floors and interacting in the patient rooms. And so there was a lot of planning and discussion and assuaging nervous people about that. How do you transport COVID patients to imaging? And then the whole aerosolizing procedure issue, which others have talked about. We've had a lot of ongoing PPE facts and anxiety discussions. We actually have kind of rapid response PPE teams in the hospital that can respond to any unit or area with a cart, with extra supplies, with on-demand teaching. We're doing N95 fittings almost every day to make sure that as we rotate through different types of N95 masks, because that's what's available at the time, we're making sure everybody is fitted appropriately and has access to something that works. If you can't be fitted for an N95, we have the PAPRs, the hoods, and we now have a hard N95 mask with a gel seal and a replaceable filter in it. How do you clean patients' rooms and how do you clean the procedure rooms has been an issue. If your hospital is requiring you to do a 2-hour delay between aerosolizing patients, can you handle that with your equipment? Should you designate some equipment as COVID only if you can? You should really be thinking about these issues. And then who gets in and who needs care. And I say we, meaning the hospital and I, have spent quite a bit of time talking with people and reaching out and virtually touching to make sure that people are managing their own wellness. We are all very concerned about patients, but as leaders, we also have to be very concerned about our staff and how are they coping. Many people have great anxieties that they're just not letting out. So we need to make sure that we're handling those, giving those people appropriate resources. So our number one priority right now is when to start the recovery phase. We're all doing planning, but until our governor lets us go, there's not much we can do. We are working within the hospital to address physical plant issues. This will guide my daily capacity. How many patients can I bring through the department? Figuring out how to separate urgent cases and cases that were postponed but now need to be seen. There are people that could have been postponed for 6 weeks but can't be postponed for 8 weeks. We got to sort through those. How to reintroduce furloughed staff, how to reintroduce physicians from home. And we're just getting to that point, and there is people's anxieties over coming back to the hospital. How do I convince patients to come back in? The people that need to come back in and the people that might have come in normally as outpatients and we've kind of deferred, they may not want to come back to Boston. Just a last bit here for what might we consider in under-resourced regions. It's all about PPE. Do you have access to it? Can you maintain yourself in a safe manner if you have limited access to it? In other words, reprocessing, reuse. What do you do with all of the discarded PPE and protective coverings? Can you maintain that as well? Can you get rid of it and keep it safe? Because what you don't want is contaminated supplies getting out into the public, getting reused, and now being a source of spreading the contagion. Can you clean and maintain your environment? And then as a big overlying question, does interpretation need to be local? Can it be regional or national or even international? So if you can't handle it locally, how easily can we ramp this up internationally? And how much imaging is really needed? How much imaging is needed really I think is part of availability of testing. In China, there was an awful lot of X-ray imaging used for diagnosis because there wasn't on-the-ground testing. If you have a good amount of lab testing, do you need to be doing much imaging? We found that we really don't need to be doing a whole lot of imaging, much less than we thought we would. And then if your resources are limited, do you regionalize your imaging for COVID and non-COVID? So with that, we can discuss any of these things in the questions. Happy to do that, and I'm absolutely happy to communicate with anybody that wishes to reach out with me. I would remind people to please always remember to be safe, compassionate, and kind in these times. All of those are needed.
Thank you so much. That was excellent, Dr. Halen. I would like to welcome our next panelist, Dr. Rito Ensman. Dr. Ensman is a professor and chair of radiology at University of California, Los Angeles. I would like to welcome you, Dr. Ensman, and you can share your slides whenever you're ready.
I'm trying. Someone's still using it.
Dr. Halen, you might have to stop share. There we go. Excellent. In the meantime, there are some questions in the Q&A box. If the panelists have time, they can answer the questions in the Q&A box. There we go. Thank you so much. We can see the slides now.
Okay. So fortunately, many of the points have been made, so I can just enhance some of the previous points made. So first of all, everybody's noticed there's what I call an imposed envelope for practice. We had to follow government guidelines, rules, and policies. UCLA put together a command center that determined policies for all of the UCLA health system and certainly for radiology. I would note that one of the issues early on, and probably is passed to some extent, but it's important on the safety side to define PPE policies, which is critical for reducing anxiety for both employees and patients. And that initially was somewhat of a moving target depending on the availability of the PPE. So for UCLA Radiology, we never really fully closed. We've always left it up to the patient. If the patient wanted a study, we performed it. Other than, let's say, the restrictions placed on us in the OR for procedures in IR. Some of the key issues, one was we decentralized and put together policies for enforcing what I call physical distance. As often is the case with crises, current trends simply are accelerated or magnified. So we've been putting together a plan for home workstations for 2 years. It's a trend already in place. We simply accelerated it and added another 15 or 20. So most of our faculty had workstations. We redesigned our reading rooms to maintain the physical distance. And obviously, as other people have already mentioned, we arranged the waiting rooms to, again, to provide the physical distance. We made sure that every subspecialty section in the department always had an in-house presence in all of our hospitals. In other words, there was always a radiologist available for consultation. And then we spent a bit more time defining our shifts. That was probably a bit loosely defined prior to the crisis, but the crisis resulted in more defined shifts all the way to 11 p.m. So we like to kind of work off data. This is an example of just showing the overall diagnostic radiology volume per week. The blue line is last year, the orange line is this year. You can see, as everybody has mentioned, a rather precipitous drop off in volume, primarily because of the mandates in terms of the openness of the healthcare system for certain procedures. So the overall decrease was 50 or 60% in overall volume. And here's an example where, again, it was the mandates that really determined our volume and our decreases. This is an example of mammography, the diagnostic mammograms versus screening mammograms. You can see there was a much bigger drop off in screening mammograms simply because that was a mandate that all screening studies were to be delayed in the entire system. So now we noticed one trend, and I think it's been alluded to, is that the diagnostic volume was not homogeneous. It was a heterogeneous response. And we've noticed as others that oncology patients tend to maintain their need or desire for imaging. So here's an example of comparison the overall diagnostic volume drop off in orange versus PET-CT, and you'll notice that PET-CT dropped off a bit, but not very much. So the oncology volume was maintained. So again, overall, significant drop in volume, but much less in oncology. Also did a comparison between diagnostic studies and interventional procedures, and you can see both of them dropped off in concert. And the main reason for that is interventional radiology was mostly an inpatient procedure. In other words, most of the procedures were in the hospital was shut down, and therefore the IR volume dropped in concert. In preparation again for oncology patients, we often do biopsies, and you can see that because the IR biopsies were done in the hospital, those procedures dropped off in concert with IR overall. These are curves that are smoothed out a bit using a 4-week moving average, but you can see that this basically reflects the decrease in hospital procedures. IR ablations are obviously an oncology treatment, and it was the same thing, except that the ablations didn't drop off as quickly. But again, it was close to the same pattern, and it was, again, primarily because the IR ablations were performed in the hospital. And you can see again, I'm focusing on the oncology practice, the diagnostic portion where PET-CT is the surrogate measure, and the IR ablations, you can see overall that those volumes did not drop off as dramatically, and IR ablations dropped off even a bit slower. Again, these are 4-week moving averages. And you can see here that PET-CT again maintained its volume, but IR biopsies initially held up and then they dropped off also. So we expect that there'll be a resurgence of the need for these type of procedures and biopsies as we open up again. So overall, we are doing it already, but we'll again pursue what I'll call after action reviews. But fundamentally, the COVID crisis was a stress test for our system, for the healthcare system as a whole. It was basically a stress test for radiology. So what have you learned from this? Well, some of the lessons are probably what I would consider fairly straightforward and obvious. There is some value in diversifying your radiology department into both diagnostic and IR and procedural. One way to protect against this kind of crisis is make sure that you're growing your oncology services, both diagnostic and therapeutic. To the extent you can, I mean, this may not be totally under your control, but limit the commodity type of practices and spend more time growing subspecialty practices, again, primarily oncologic. And the one thing that we already had started doing, because we were building multiple outpatient centers, but we'll probably accelerate the trend, is to move more IR procedures out of the hospital. I think it's been alluded to before, and this is part of, I think, the role of leadership is to spend time maintaining your culture. Remind everybody, including your own team, that radiologists are physicians. Do not run and hide, and show yourself. And above all, something I like to do personally, but I encourage all my faculty, thank the technologists, nurses, administrative staff, because they are truly your front line in taking care of patients and in this risky environment. Thank you.
Thank you so much, Dr. Hensman, for the inspiring presentation and the useful tips. Really appreciate this. Next, we have Dr. Pallav Kohli. Dr. Kohli is the Associate Chair at Department of Radiology at UCSF. And Dr. Kohli will be talking about initiatives at UCSF.
Thanks, Dr. Rahani and Dr. Dillon, for this invitation. And it's an honor to be amongst these panelists. Dr. Hensman, I think, would you be able to stop sharing and I'll pull up my slides?
Let's see, how do I get there?
There should be a stop share button at the bottom. There we go. Yeah, and then.
So I can sort of start talking. I think Dr. Norbash really hit on something that we've seen here at UCSF and across the UCs, which is we prepared for sort of disaster, with California being not quite as early as Washington, but really early affected in this pandemic. and expected perhaps to look a little bit like, I think I can't share yet, sorry, like New York looks today. And in fact, I've seen much lower volumes.
Dr. You might have to stop share. I think we can still see your screen. There we go. I think now, Pallav, you can try right now.
Great, thanks.
Perfect.
So we prepared for a much worse situation than we expected to see. And in fact, in sum total, since the beginning of the pandemic, we've hospitalized 83 patients. And at any given time on the East Coast, hospitals may have more patients than that. We have seen huge revenue losses. I saw a figure the other day of $210 million expected revenue loss. I can't remember if that was through April or May as a health system. And an important point, I think, is I've learned we have very strong health system leadership that really helps guide policy and guideline development at a system level rather than at a department level. Let's see. And so I thought I would focus on, we're in this sort of flattened curve and probably what's a new normal for, 6 to 18 months. So what does that look like through the lens of safety primarily, which is a topic that I sort of oversee for our department, and a little bit about operations and communications. So focusing on safety, I always talk to our team and I say, well, really, in terms of preventing transmission either between patients or to healthcare workers, there are two central components, right? One is minimizing interactions with patients who have COVID-19 or healthcare workers who have it. And two is making interactions as safe as they can be. And so how do we minimize interactions with patients who actually are infected with COVID-19? And I think we have a whole system of screening, but the key has been these phone calls 24 to 48 hours ahead of actually all appointments, diagnostic or interventional appointments. We have a standard screening tool developed by the health system that goes through sort of the CDC symptoms as well as exposure risks. And thereby we, if appropriate, divert patients or defer their appointments if they have symptoms and arrange for them to be seen in our respiratory screening clinics and get appropriate testing. And of course, transmission occurs not just from patients to healthcare workers, but potentially from healthcare workers between each other. Again, this is done at the system level. We all go through a screening questionnaire every morning. And if there are positive screens, there are appropriate actions developed by occupational health. The other thing that has been very beneficial to us, and we, I think most places have an electronic health record at this point, but is how do you identify patients who maybe at the time of scheduling an appointment were not infected with COVID or did not have a test pending, but now they may. And so the electronic health record flagging has been critical to this, as well as those flags show up in all of our scheduling and technologist work lists. And so we're able to sort of review at the time of scheduling, but also the day before any given work and determine, has the status of this patient changed, and should we change the plan, either defer imaging or procedure, or do so and change how we proceed with that imaging or procedure in the safest possible manner. And I think when we come to recovery, the real question is what is the role of testing of asymptomatic patients? And so this is data from our health system of case positivity of testing, and admittedly a much lower prevalence area, the Bay Area, compared with sort of the East Coast, but our symptomatic patients test positive at 3.3 case rate. And interestingly, we've done a lot more asymptomatic testing in the last 3 weeks, more than 3,000 tests, and that is all admitted patients. And as we look to recovery, the question is, in an ideal state, you would test everyone coming in through the door. Of course, that requires a high throughput test that gives you quick results and can be done at the point of care. And we certainly don't have that. And so you have to be selective about how you test. And at present, what we're doing is testing patients who are in high-risk situations. So anyone who's going to undergo something aerosol generating, in other words, general anesthesia, or certain procedures that are considered aerosol generating. And that has been controversial, I think, across health systems. We are using the Society of Interventional Radiology classification for that. We at our system are not currently testing asymptomatic healthcare workers, the rationale being that if once we start doing that, you have to sort of do that on a serial basis. Otherwise, you just sort of get a one-time safety check. But we're all going to grocery stores and having limited interactions outside of the healthcare system. So unless you're doing that on a serial basis, it's unclear the overall benefit of that. Now, we have preached, look, we are a health system that takes care of patients who are infected with COVID-19. you know, we would like to minimize those interactions, but all interactions need to be as safe as possible, assuming that anyone could potentially be infected. And I think many healthcare systems, but I think as this is an international audience, I think one of the critical interventions that should be taken ideally at a health system level is a universal surgical masking policy for a disease that is primarily a droplet spread. And paired with that is, I think we have seen over the course of 2 months, improvements in supply chains, but we still have overall PPE shortages worldwide. So good, safe practice and policy in terms of how you can safely reuse personal protective equipment or use it, or what we call extended use. And then how do we sort of interact with these patients in a safe manner beyond personal protective equipment, but having workflows that are safe? Early in this pandemic, we really concentrated on how can we safely image when necessary patients who are either patients under investigation or infected. In the last couple of weeks, what we realized is we acquire a cohort of patients who've tested positive in the outpatient world and either convalesced in the outside world or have been discharged. There are uncommon, but situations where these patients actually need to be imaged as outpatients. For example, new leg swelling, rule out DVT. And so we're really trying to figure out, we've sorted out a workflow to safely image outpatients who are either patients under investigation or infected, while minimizing interactions with other patients and staff at cohorted specific sites. And PPE use, so defining it is one thing, but educating all the folks in your department how to safely use PPE and what situations require which specific PPE was a huge undertaking that over the last 8 weeks, including not just for diagnostic imaging, but this is a chart we put together for procedures, whether they're under general anesthesia or local anesthetic, and whether they're aerosol generating or not. So looking at recovery, we realized that as we expect an increase in volume, what do we do about the other places where patients congregate, the waiting rooms? And so we have spaced outpatient appointments and expanded hours to try to maintain volume capability. We're looking at streamlining registration. So when a patient comes in, rather than spending a bunch of time filling out paperwork and doing insurance, how much of that can be done electronically so that interaction is as brief as possible? And as others have mentioned, redesigning waiting rooms to remove space and furniture and thinking differently. Are the waiting rooms also potentially the outdoor spaces around our hospitals and clinics, or perhaps patients' cars? And we're sort of going live with a patient texting within our electronic medical record today, so we'll see how that goes. I had some questions about safety of radiology reading rooms. I'm sure that these are fairly common practices across most sites. The question is as we end up with increase or recovery of volumes and people want to come back to work, how do we maintain physical distancing and safety? And so I think that's something that's front of mind in the last week or so. And what we're looking at is how can we distribute workstations to really maintain 6 feet of physical distance? How can we optimize readouts, as Dr. Halen mentioned, over Zoom, even if you're potentially in the same room? And really thinking about, some partial work from home as a new reality in order to allow that physical distancing to be maintained. In the interest of time, I won't talk too much about operations. I want to echo what all have said, is that really in a time of anxiety, it's turned out that rapid and over communication has been critical. This is a little bit of what we're doing now. It's actually tamped down. We used to have a sort of leadership meeting daily and a manager's huddle daily. And we've decreased that a little bit, but really you can't over communicate in a situation like this. One thing that's been, I think, very helpful to us, and I'll skip forward, is setting up a website for our department. Our health system has a COVID resources website, but what we found is we needed radiology specific information available for reference, and we made this publicly available in case the information is helpful. It's got a lot more detail about our safety policies and procedures and how we're managing the COVID pandemic. And then as we look at recovery, I think the final point about communication is it's time to engage with our patients. So we have in the background an email that went out to all UCSF Health patients, sort of sharing the safety measures that have in place and encouraging patients to return for previously deferred medical care. And these are signed, in the front is a sign that's placed in all the waiting rooms and everything. So we'll see. I mean, we certainly have seen that even when trying to schedule patients, patients are concerned and are not necessarily enthusiastic about returning to the healthcare system at present. And that'll be a challenge, I think, to recovery in radiology. So I'll just close with these positive thoughts of things I've learned in the past 2 months. It turns out that when you want to make changes in the electronic medical record, it doesn't take 12 months once you have everyone focused on doing things nimbly. Great ideas come from everywhere, not just from leaders. And I think most encouragingly, what I found is people want to feel safe, but after that, most people I work with really just want to know how they can help and how can we do things better and safer. And that's really been, I think, a positive note I've seen in the last couple of months. So let me stop there. And thanks again to all the panelists and Dr. Rouhani and Dylan for having me here.
Thank you so much, Paula. We really appreciate this. We have gone a little bit above time, so we'll just wind it up. I would really like to thank the panelists because you have answered the questions already in the Q&A box. And these questions are from, residents and faculty from around the world. So really thank you for that. And Dr. Dillon, would you like to just talk about the Academy in a minute and then we can just wind it up?
Sure, and thank you all for participating, all of the registrants around the world and our panelists. They were superb, and this recording, as well as others, will be available for everyone without any charge on the healthfortheworld.org website. It's called Health for the World Academy. There's a number of lectures, so feel free to see those. This one will probably be up by tomorrow for sure. There's some other ones on the same kind of topic from other leaders around the world. And I'll just close by saying a couple points that were made, that talent emerges from crises like this. Things happen fast. And the other thing I'd point out is the importance of radiology to the financial well-being of an organization has never been so clear. This is a great opportunity for radiology to demonstrate fully its value to the healthcare enterprise. And that's being recognized, I think, as we open up and people recognize that radiology and the things that we do every day are so important to not only our patients, but the fiscal health. So thank you all very, very much. And I look forward to speaking with you in the future through probably Zoom.
Thank you, everyone. Thanks to the panelists for your really helpful comments. You have helped so many radiologists around the world today by doing this for us. And thanks for our global radiology family for joining us. We would just wind up with these two beautiful quotations. One is by the Dalai Lama, be kind whenever possible, it's always possible. And by Viktor Frankl, we don't get to choose our difficulties. We do have the freedom to select our responses. Let's choose to do good together. Thank you so much, everyone. And we really appreciate you doing this for us and joining us today. Have a wonderful day.
Thanks, everybody.
Thank you.
Thank you.
Thank you.
Thank you, folks. Thank you.